Assalamu alaikum, myself Mehak Asghar. I am from chemistry department and today the topic of my presentation is urinary tract infections. So let's get started. These are my outlines. What is UTI? The science behind UTI, why UTIs happen, chemical and biological events, modern diagnostic approaches, treatment science, epidemiological and statistical data, prevention and sustainable biomedical strategies, current research frontiers, summary and then references. Urinary tract infections. A urinary tract infection is an infection caused by microorganisms, most often bacteria, that enter and multiply in the urinary tract, leading to inflammation and symptoms such as pain or burning during urination. Parts of urinary tract infection. Urinary tract infections can affect any part of the urinary system. The urinary tract has four main parts. An infection can occur in one or more of them. Number one, kidneys. Function. It filters waste from the blood and make urine. Infection called pyelonephritis. Symptoms include fever, chills, back, flank pain, nausea and vomiting. Severity. Serious infection can spread to the bloodstream if untreated. Ureters. Function. Carry urine from the kidneys to the bladder. Infection rare on its own, usually part of a kidney infection. Symptoms similar to kidney infection, pain in the side, fever. Bladder. Function. Stores urine until it is released from the body. Infection called cystitis, most common type of UTI. The symptoms are burning when urinating, frequent urination, lower abdominal pain, cloudy urine, etc. Urethra. Function. Tube that carries urine out of the body. Infection called urethritis. Symptoms include burning sensation while urinating, discharge and irritation at the urethral opening. Pathophysiology. The science behind UTI. A urinary tract infection develops when microorganisms, most often bacteria, enter and multiply within the urinary system, urethra, bladder, ureters or kidneys. Normally, the urinary tract is sterile due to several defense mechanisms, but when these defenses are breached, infection can occur. Route of infection. Ascending route, this is the most common. Bacteria from the gut flora, especially E. coli, migrate from the perineal region to the urethra. They ascend into the bladder, causing cystitis, bladder infection. If not controlled, they can travel up to the ureter to the kidneys, causing pyelonephritis. Common in females because of shorter urethra, proximity of urethral opening to anus and vagina. Hematogenous route, less common. Pathogens spread through the bloodstream from the other infected sites, for example, E. coli from the skin infections, and seed the kidneys. Lymphatic spread. Rare infection spreads through lymphatic channels connecting bowel to urinary tract. Mechanism of infection. Once bacteria reach the urinary tract, adhesion. E. coli attach to the urinary epithelium using fibri, hair-like structures that bind to receptors on uroepithelial cells. Invasion and colonization. After adhesion, bacteria multiply and may form biofilms, protecting them from immune attack and antibiotics. Host inflammatory response. Bacterial toxins and cell wall components stimulate epithelial cells. This triggers release of cytokinesis. Neutrophils migrate to the site, pus in urine, and inflammation. Tissue damage. In the bladder, irritation of mucosa, pain, urgency, frequency in kidneys, inflammation, edema, and possible necrosis, fever, flank pain, systematic symptoms. Pathophysiology of UTI is caused by the other pathogens. The pathophysiology of UTI depend on pathogen virulence factors, adhesion, biofilm, enzyme production, host defenses, urinary flow, and immune status. Presence of foreign bodies, catheters, and stones. Underlying health conditions, diabetes, obstruction, and immunosuppression. While E. coli accounts for 70 to 90% of community-acquired UTIs, other pathogens can also cause infection, especially in hospital settings. Patients with catheters are those with underlying diseases. Let's go through one by one. Klebsiella species. Type: gram-negative bacilli and encapsulated. Mechanism of infection: the capsule protects against phagocytosis and complement mediated killing. Fibric help in adherence to the uroepithelial cells, produces urease, which breaks down urea, increases urine pH, favors stone formation and bacterial growth. Clinical impact. Often causes complicated UTIs, and catheter-associated infections may lead to steroid stones due to alkaline urine. Protease species. Type: gram-negative motile bacillus. Mechanism of infection: swarming motility helps bacteria ascend the urinary tract. Urease production splits urea into the ammonia, alkaline urine, promotes precipitation of magnesium, ammonium phosphate, steroid stones. Biofilm formation on catheters and stones protects against antibiotics and host defenses. Clinical impact are common in recurrent and catheter-associated UTIs, can lead to renal calculi, stones, and chronic infections. Pseudomonas aeruginosa. Type: gram-negative non-fermenting bacillus. Mechanism of infection: adhesions and biofilms allow persistence on catheters and uroepithelial surfaces. Produces exotoxins and enzymes that damage host tissue. Intrinsic resistance to many antibiotics makes infection harder to treat. Clinical impact: common in hospitalized and catheterized patients, leads to chronic, difficult to treat infections. Enterococcus faecalis. Type: gram-positive cocci. Mechanism of infection: uses accretion substances and surface adherent to attach to uroepithelial cells and catheters. Form biofilms on medical devices, resistant to many antibiotics including VRE strains. Clinical impact: common in elderly, poor surgical or catheterized patients. Can cause ascending infections that lead to pyelonephritis. Staphylococcus saprophyticus. Type: gram-positive cocci. Mechanism of infection: has adherence for uroepithelial cells and urease enzyme. Resists urinary flow clearance due to tight adhesion. No biofilm but high tissue tropism for urinary tract mucosa. Clinical impact: second most common cause of community-acquired UTI in young sexually active women, usually cause acute cystitis, bladder infection. Candida species yeast. Type: fungal pathogen. Mechanism of infection are adheres to urinary catheter surfaces and form biofilms, can invade mucosa or enter the bloodstream in immunocompromised patients. Clinical impact are causes fungal UTIs mostly in hospitalized or immunosuppressed individuals, associated with the indwelling catheters and broad spectrum antibiotic use. Why urinary tract infections happen? Urinary tract infections are one of the most common bacterial infections, especially in women, but they can affect anyone. Let's go through why they happen, what causes them, and what risk factors increase the likelihood of infection in detail. Bacterial entry. The most common route is ascending infection, meaning bacteria travel up from the urethra into the bladder and possibly to the kidneys. The main culprit is E. coli, responsible for 80 to 90% of UTIs. E. coli normally lives harmlessly in the intestines but can cause infection when it enters the urinary tract. Adhesion and colonization. Once bacteria reach the urinary tract, they can adhere to the lining using pili. Tiny hair-like structures resist being flushed out by urine, multiply and form biofilms, protecting them from immune responses and antibiotics. Host responses are: the body's immune system reacts, causing the inflammation, leading to the symptoms like pain, burning, and urgency. In severe cases, bacteria may ascend further, causing kidney infection or enter the bloodstream. Risk factor for UTIs occur more easily when bacteria gain access to the urinary tract or when the body's defenses are compromised. Anatomical and physiological factors, behavioral and hygiene factors, medical and procedural risk factors. Anatomical and physiological factors. Female anatomy. Women have a shorter urethra, about 4 cm compared to the men, that is 20 cm. The urethral opening is closer to the anus and vagina, increasing bacterial contamination risk. Pregnancy. Hormonal changes relax ureters and bladder, causing urinary stasis, slow urine flow. The enlarged uterus can compress the urinary tract. Menopause. Decreased estrogen levels lead to changes in vaginal flora. Thinning of urethral tissues makes infection easier. Urinary stasis. Any condition that prevents complete bladder emptying, allows bacteria to multiply, causes enlarged prostate, bladder stones, neurological disorders, or urinary catheters. Behavioral and hygiene factors. Sexual activity. Friction can introduce bacteria into the urethra. Honeymoon, cysticity, first UTI after sexual intercourse. Use of spermicides or diaphragms alters normal vaginal flora and promotes bacterial growth. Poor perineal hygiene. Whipping back to front can transfer bacteria from the anus to the urethra, holding urine for long periods. Promotes bacterial growth. Low fluid intake reduces urination frequency, allowing bacteria to multiply. Medical and procedural risk factors. Urinary catheters associated UTI. Major risk in hospitalized or immobilized patients, bacteria can ascend along the catheter surface. Diabetes mellitus, high urine glucose levels, pores bacterial growth, immune response increases susceptibility, immunosuppression from medications, for example, corticosteroids, chemotherapy, or diseases, for example, HIV. Structural abnormalities, vesicortical reflux, urine flows backward from bladder to kidney. Kidney stones harbor bacteria and obstruct flow. Recent instrumentation, procedures like cystoscopy or catheter insertion can introduce bacteria. Chemical and biological events in the urinary tract infections. Let's break down the chemical and biological events that occur during urinary tract infections, from the initial bacterial entry to the host immune response and biochemical changes. Entry and colonization. Pathogen entry. Most common pathogen E. coli, especially uropathogenic strains. Route ascending infection, bacteria from the periurethral area enter the urethra and migrate up to the bladder and sometimes kidneys. Predisposing factors, short urethra, especially in females, catheterization, obstruction, poor hygiene. Bacterial adhesion, pili. UPEC uses type 1 fibri and P fibri to attach to the uroepithelial cells receptors. Glycolipid and mannose contain receptors on bladder epithelium. Chemicals from event-specific ligand-receptor interactions allow strong adhesion, preventing bacteria from being flushed out by urine. Invasion and biofilm formation. Invasion. Bacteria invade epithelial cells, forming intracellular bacterial communities. Chemical signaling regulates gene expression for invasion and survival. Biofilm formation. Biofilms are made of extracellular polymeric substances, polysaccharides, proteins, and DNA. Chemical event: EPS, matrix traps, nutrients, and resist antibiotics and immune attack. Host immune response, innate immune activation, pattern recognition. Toll-like receptors detect bacterial components like LPS, lipopolysaccharide, and flagellin. Chemical mediators released. Cytokinesis attract neutrophils, chemokines recruit more immune cells, reactive oxygen species and nitric oxide released by neutrophils could kill bacteria. Inflammation. Inflammatory chemicals cause vasodilation and increased vascular permeability, more immune cells access. Pain, burning sensation, urgency due to irritation of bladder nerves. Pyuria. Presence of pus white blood cells in urine due to the inflammation. Tissue damage and the chemical changes. Cellular damage. Bacterial toxins like hemolysin and cytotoxic necrotizing factor cause epithelial damage. Slowed epithelial cells appear in the urine. Urine chemistry changes. Increased pH, especially with protease infection that produces urease, elevated nitrites from bacterial nitrate reduction, presence of leukocyte esterase enzyme from neutrophils, possible proteinuria and hematuria, protein and blood in urine. Systemic spread in severe cases. If infection ascends to the kidneys, bacterial products and cytokines enter bloodstream. Fever, chills, systemic inflammatory response. In severe cases, urosepsis may occur. Modern diagnostic approaches for urinary tract infection 2024-2025. Traditional baseline methods. Urinalysis and urine microscopy remains first-line rapid test for symptomatic patients. They are quick and cheap but imperfect. Quantitative urine culture is still the clinical reference for identifying organisms and performing the conventional AST. Turnaround is usually 24 to 72 hours. Modern diagnostics, bigger gains in speed and sensitivity, and NATs, multiple PCR panels detect pathogen, DNA, RNA directly from the urine with much faster turnaround than culture and higher sensitivity, especially for fastidious organisms, useful for symptomatic patients and for complex recurrent UTI workups. However, NATs can detect low-level colonization or non-viable organisms. Interpretation must consider clinical context. Isothermal methods, LAMP and CRISP-based assays are being developed and early tested for very rapid low resource POC use. Some CRISP approaches for uropathogen detection were reported in 2024 and 2025. Rapid organism identification from the urine. Maldi-Toff mass spectrometry, well established for ID from colonies and increasingly adopted for direct from urine workflows to shorten time to ID by passing overnight culture in selected samples. Recent work focuses on the method standardization and expanding direct urine accuracy. Rapid antimicrobial susceptibility testing AST, the major recent advance. Next generation rapid phenotypic AST platforms, microfluidics, impedance, optical growth analysis, single cell flow cytometry approaches can deliver susceptibility results in minutes to a few hours rather than days. These aim to provide phenotypic rather than just genotypic AST to so can pick an effective antibiotic more reliably. Promising reports and reviews appeared in 2024-2025. A notable practical breakthrough in 2024, a cartridge-based system that the longitude price panel highlighted claims identification in 15 minutes and antibiotic guidance with 14 minutes. Such devices are examples of how rapid AST is moving from lab research to near clinical development. Detecting antimicrobial resistance genotypic approaches. AMR gene detection PCR panels targeted NGs can quickly identify well-known resistance determinants. This helps flag resistant infections early, but absence of a known gene does not guarantee susceptibility. Metagenomics NGS. Shotgun metagenomic sequences from urine can identify mixed infections, rare fastidious organisms, and broader resistome profiling. It's most useful in complicated, prolonged, or culture-negative cases and in research epidemiology. Cost, processing time, and interpretation complexity limit routine used today. Biomarkers and host response test research into the host biomarkers aims to distinguish true infection from colonization and to identify patients at risk of complications. These are promising but not yet universally adopted into the guidelines. They complement rather than replace pathogen detection. Treatment science first line antibiotics based on IDSA and WHO 2024. Uncomplicated lower urinary tract infection, acute cystitis in otherwise a healthy non-pregnant woman. First line options. According to the IDSA, 2010 guidelines for uncomplicated cystitis and pyelonephritis and more recent literature neurofuranate monohydrate 100 mg twice daily for 5 days is appropriate. Trimethoprim double strength tablet 160 by 800 mg twice daily for 3 days, but only if local resistance of uropathogens, especially E. coli, is less than 20. Phosphomycin trometamol single 3-gram dose where available is also an appropriate choice. In regions where the available may also be first line. Key caveats. Fluoroquinolines are generally not recommended for the first line treatment of uncomplicated cystitis if the above options are viable because of increased collateral damage resistance issues. Appropriate therapy must consider local resistance patterns, then avoid its empiric use. Duration of the therapy is typically short in uncomplicated cases, for example 3 to 5 days for appropriate agents. Asymptomatic bacterium generally should not be treated in non-pregnant patients. Upper urinary tract infections or complicated UTI. When the infection involves the kidneys, fever, flank pain, men, catheterized, associated structural abnormality, immunocompromised, the guidelines for the complicated UTI apply. Key points from the latest IDSA updates. The newer 2025 IDSA guidelines on complicated UTIs emphasizes tailoring therapy based on patient specific risk factors, prior antibiotic exposures, and local antibiogram. They suggest for suspected complicated UTI including pyelonephritis to use an antibiotic with known activity, ideally guided by the culture, and switch to an oral option when feasible. For outpatients with pyelonephritis, fluoroquinoline may still be considered. RTMP of known susceptible but local resistant patterns are the crucial. Novel and sustainable treatment strategies. Anti-biofilm and anti-adherence strategies. Many uropathogens, especially E. coli, form biofilms or intercellular bacterial communities in the bladder epithelium which reduce antibiotic penetration. For example, one recent article describes intravasically delivered polymeric nanogels conjugated with the cell-penetrating peptides to deliver gentamicin directly to bladder tissue and IBCs, showing less than 90% greater than 90% clearance in urine model of the Pseudomonas UTI. Nanotechnology and the drug delivery optimization. A recent study describes sustainable nanophytosomes made of ketosine, a natural polymer, encapsulating rosemary oil to treat MDR E. coli UTIs in animal models. The system reduces bacterial load in urine, bladder, and kidney, lower inflammation, and uses environmentally friendly materials. More broadly, nanoparticles have been proposed not only for the improved antimicrobial delivery but also for green manufacturing sustainable materials. Nutritional adjunctive preventive strategies. A 2023 review looked at novel ingredients such as D-mannose, chondroitin sulfate, hyaluronic acid, and N-acetyl cysteine (NAC) for urinary tract health. Another recent review 2024 described the evidence-based new vista to reduce antimicrobial use in UTIs via natural products, non-antibiotic approaches. What to tell patients practice? Encourage hydration, avoiding habits, good urinary hygiene. Agents like D-mannose, if locally available, may be considered in recurrent UTI patients, not as sole therapy. Emphasize that these are complementary, not replacement for antibiotics when needed. Monitored evidence, many studies are small, heterogeneous, so context-specific decisions are needed. Preventive vaccines and immune modulation. For example, the oral bacterial extract vaccine Urovaxone OM89 comprising killed E. coli strains has been used in some countries to prevent recurrent UTIs. Immunomodulation stimulating host defense locally is gaining interest as a sustainable way to reduce recurrent infections rather than repeatedly treating them with antibiotics. Fewer infections, fewer antibiotics, less resistance, particularly valuable in recurrent UTI setting. Women with multiple episodes per year aligns with prevention over cure, which is inherently more sustainable. Epidemiological and statistical data, global large-scale data, incidence and prevalence. According to the Global Burden of Disease Study to the 2019, GBD 2019, there were 4.6 million individuals with UTIs globally, 25% UI 59.4 to 446.5 million. The age standard the incidence rate rose from 4,715 per 1 lakh population in 1990 to 5,229 per 1 lakh in 2019. From 1990 to 2019, global case rose by 65.5% from 2.570 billion to 4.49 billion, according to another analysis of the 2021 data. In oncologic patients with cancer, a meta-analysis found a pooled UTI prevalence of the 34.39%, mortality and dailies. In 2019, there were 236,786 deaths globally attributed to UTIs and 5.2 million DLBIs, disability adjusted life years lost. For healthcare associated UTIs, prevalence in hospital settings is quoted 12.9% CI, 10.2 to 16% in general, 19.6% in US, 24% in developing countries. Prevention and sustainable biomedical strategies for urinary tract infections. Prevention and sustainable biomedical strategy for UTI involve lifestyle changes, natural supplements, and advanced therapies. These include staying hydrated, proper hygiene, and post-coital urination, alongside natural remedies like cranberry and probiotics. For recurrent infections, approaches like a new sublingual vaccine, vitamin D, and nanotechnology-based delivery of natural compounds offering promising, sustainable, and non-antibiotic alternatives. Lifestyle and hygiene practices: stay hydrated, drink plenty of fluids, especially water, to help flush bacteria out of the bladder and urethra. Practice good hygiene. Wipe from front to back after using the toilet to prevent bacteria from the anal region from entering the urethra. Urinate frequently. Don't hold your urine for long periods and try to empty your bladder completely. Urinate after the intercourse. This helps flush out bacteria that may have entered the urethra during sexual activity. Natural and supplemental strategies. Cranberry products may be effective by preventing bacteria from sticking to the bladder wall, particularly with the products containing proanthocyanidins. Probiotics may help restore beneficial bacteria, especially lactobacillus species. Vitamin C can help acidify the urine and is sometimes used with the methionine to create formaldehyde in the bladder, which has antibacterial effects. Vitamin D plays a role in immune function and may support bladder Epithelial integrity. Vaginal estrogen for post-menopausal women with recurrent UTIs. Estrogen therapy can improve the condition. Can improve the condition. Herbal extract, various plant extracts like those from the palmetto, garlic, ginger, and turmeric show promise for their antimicrobial and immunomodulatory effects. Advanced and sustainable biomedical strategies, sublingual vaccine, a promising new vaccine that targets the immune response, showing up to a 60 to 70% reduction in UTI occurrences in trials with minimal side effects. Nanotechnology, developing drug delivery systems such as nanophytosomes using natural compounds like rosemary oil can enhance the efficiency of antimicrobials and provide more sustainable treatments. Immunomodulation therapies that support the body's own immune system like vitamin E supplementation may help reduce symptom severity by improving the integrity of the bladder lining. Current research frontiers for UTIs in 2024-2025 include developing faster and more reliable diagnostic methods like flow cytometry, understanding and treating recurrent UTIs through mechanisms like bacterial persistence and intracellular communities, and managing the growth threat of antibiotic resistance by monitoring uropathogen profiles and developing new drugs like pivmecilin. Diagnostic tics and monitoring. Approving diagnostic accuracy research continues to explore limitations of traditional methods like urinalysis and urine cultures to better differentiate between asymptomatic bacterium and true UTIs. Faster testing flow cytometry is being investigated as a faster and more reliable alternative to traditional urine culture for diagnosing UTIs. Tracking resistance monitoring uropathogen profiles and antimicrobial resistance patterns is a key research area to inform effective empirical antibiotic therapy. Recurrent UTIs and new therapies. Understanding bacterial persistence. New insights are being gained into how bacteria can persist in the bladder and between infections, leading to a better understanding of recurrent UTIs. Targeting intracellular communities, research is focusing on the role of intracellular bacterial communities in the recurrent infections and exploring new treatment strategies like pulsed antibiotic therapy with intracellular activity. Novel antibiotics, the 2024 approval of pivmecilinium for uncomplicated UTIs in women represents a new treatment option, particularly for infections caused by drug-resistant bacteria. Other areas of research. Risk factors. Studies are investigating risk factors with some recent research focusing on the link between UTIs and the preterm birth as well as socio-demographic factors. New classification systems are being developed to classify UTIs such as the European Association of the Urologists proposed localized versus systematic classification to improve the treatment approaches. Multidisciplinary management research is also highlighted the need for a multidisciplinary approach for complex cases such as those in immunocompromised patients or individuals with anatomical abnormalities. Summary. Urinary tract infection represent one of the most common microbial infections affecting individuals across all age groups and genders too. They are particularly prevalent in women due to the anatomical and physiological factors. Fundamentally, a UTI is defined as a microbial infection of any part of the immune system, including the urethra, bladder, uterus, or kidneys. The primary causative agent behind most UTIs is uropathogenic E. coli, which is responsible for approximately 80 to 90% of all community-acquired cases. UPEC, a specialized strain of E. coli, possesses a variety of virulent factors that enable it to colonize and persist within the urinary tract. Overcoming the host's natural defense mechanism, the pathogenic process begins with bacterial adhesion, followed by the evasion of host immune responses, inflammation, and ultimately infection establishment. Bacterial adhesion is a critical first step in UTI pathogenesis. UPEC expresses specialized surface structures known as fibri or pili, which facilitate strong attachment to the uroepithelial cells lining the urinary tract. This adhesion prevents the bacteria from being flushed out by the urine flow. Once attached, UPEC can invade the epithelial cells and form intracellular bacterial communities, allowing them to persist in a protective niche that shields them from both immune responses and antibiotics. The bacteria then employ various evasive strategies such as biofilm formation and antigenic variation to avoid immune detection. This persistence triggers inflammation and leading to the hallmark symptoms of UTIs: pain, burning sensation during the urination, increased frequency, and in severe cases, fever or back pain if the infection ascends to the kidneys. Diagnosis of UTI traditionally relies on urine culture, which remains the gold standard for identifying the causative organisms and determining antibiotic susceptibility. However, this method is time consuming and may delay appropriate treatment. To address this limitation, molecular diagnostic tools such as polymerase chain reaction PCR and next generation sequencing NGS have been developed to provide faster and more accurate detection of the pathogens and their resistant genes. In addition, recent advancements in the biosensor technology have shown promise for rapid point of care detection of UTIs. These biosensors utilize electrochemical, optical, or nanomaterial based approaches to identify specific microbes markers in urine samples, offering results within minutes rather than days. Such innovations are particularly valuable in managing recurrent or complicated UTIs, where quick diagnosis can significantly influence patient outcomes. Treatment of UTIs primarily involves the use of antibiotics such as trimethoprim, sulfamethoxazole, nitrofurantoin, or fluoroquinolones. However, the growing prevalence of the multi-drug resistant MDR bacteria, including extended spectrum beta-lactamase producing E. coli, has made antibiotic resistance a critical global health concern. The World Health Organization has classified antibiotic-resistant pathogens, particularly MDR UPEC, as a highly priority threat requiring urgent research and novel therapeutic strategies to combat this issue. Researchers are exploring alternative approaches such as nanomedicine, probiotics, and bacteriophage therapy. Nanomedicine leverages nanoscale materials to deliver drugs directly to the infected sites, enhancing antimicrobial efficiency while reducing systematic side effects. Probiotics, on the other hand, help restore and maintain healthy urinary microbiota, reducing the likelihood of recurrent infections. Prevention remains a key strategy in reducing the incidence of UTIs. Basic hygiene practices, adequate hydration, and the use of probiotics have shown effectiveness in lowering infection risk. In healthcare settings where catheter-associated UTIs are common, advancements in catheter materials such as silver nanoparticle coatings, hydrophilic polymers, and antimicrobial services are being developed to minimize bacterial adhesion and biofilm formation. These innovations could significantly reduce hospital-acquired infections and improve patient safety. Recent research in UTI management has focused on integrating cutting-edge technologies such as artificial intelligence, AI, nanophages, CRISPR-based biosensing, and vaccine development. AI algorithms are being utilized to predict infection patterns, optimize antibiotic use, and analyze complex microbiome data for personalized treatment strategies. Nanophages, which combine bacteriophage therapy with nanotechnology, offer targeted bacterial killing with minimal disruption to beneficial microbiota. CRISPR-based biosensors enable ultra-sensitive and specific detection of UTI pathogens and resistant genes, potentially revolutionizing diagnostic speed and accuracy. Additionally, vaccine research is advancing rapidly with several UPAC targeted candidates under development aiming to prevent infection recurrence and reduce reliance on antibiotics. In conclusion, urinary tract infections continue to pose a significant global health burden, compounded by raising antibiotic resistance. Advances in molecular diagnosis, nanotechnology, probiotics, and AI-driven healthcare are paving the way towards faster diagnosis, more effective treatment, and innovative prevention strategies. Through a combination of improved hygiene, smarter medical devices, and cutting-edge biotechnology, the future management of UTIs holds promise for bold, sustainable, and personalized approaches to combat this persistent and increasingly complex infection. References include, these are my references, so thank you so much. Allah Hafiz.